Thank you for letting us join you. Thanks everybody for joining us today. We're going to be focusing on screening and the key issue here about how to take a good history of tobacco use and helping to work through working with patients on their willingness to quit. And so the point that person makes is that inaction really is action. If we don't make it clear to patients that quitting smoking is critical to their health, then the fallback assumption is if it's not important enough for my doctor, for my practitioner to say something to me about smoking, then it must not be very important. It is very important.
You know, today what we'd like to do is cover some basic sort of commonsensical kinds of approaches that are part of a total picture of evidence-based tobacco treatment. And we appreciate the fact that you all are with us. We're going to be preaching to the choir. What we know is true is that clinicians who do not understand how to apply evidence-based tobacco treatment actually do not help their patients, because patients really need the evidence-based strategies and do very well when they are given evidence-based tobacco treatment strategies. So, you know, things that we're going to toss out today are sort of commonsensical, but maybe you can keep a list of things. You know, are these the things that you already are aware of, or are they things that maybe you need to look into for your particular practice? I want to just run through a few basic concepts before we really dive in. Nearly a half of the adult Medicaid patients in Ohio smoke. So that is a very sad and very real statistic. And if that's true, that we have some 40 or more % of patients who are Medicaid patients who are out there in Ohio that really need our help, then we really, that's 1 out of 2 of Medicaid patients that we see. As healthcare disparities increase, so does tobacco use. And of course, tobacco use can even be related to other substances, as you're well aware, things like alcohol and other illicit drug use. But people with HIV or who are unable to claim a permanent home or are poverty status, perhaps have comorbidities of the psychiatric variety, all of these patients are at increased risk of using tobacco, and we really need to be addressing it. As you already know, I'm sure you've heard, we've talked about this before as a group, about 500,000 Americans die each year from tobacco-related illness. And sadly, that is 4 to 5 times the number from opioids. Tobacco doesn't get the press, it seems, but you know, not to diminish either topic. Both are bad and both have many preventable deaths associated, but it's very important that we do recognize just how much tobacco-related illness underlies so many chief complaints that our patients have. Nicotine is as addictive as heroin.
It's important to recognize that when we use the term tobacco today, we're not just talking about combustible tobacco like cigarettes. This includes vaping, e-cigarettes, hookah, cigars, pipes, chewing tobacco, snus, any type of tobacco, or really nicotine use other than therapeutic nicotine in forms of patches and gums and the like. Our patients want to quit. I think that's one of the great misunderstandings that many of us have as clinicians. We don't want to bring up the issue of quitting tobacco because we're afraid that our patients are going to say no, they're not interested 2/3 or more of patients want to quit smoking. They want our help to do it. The way to do it is to use the 5 A's. Ask, advise, assess, assist, and arrange. Today, we're going to focus on ask, which is all patients need to be asked about their tobacco use at every visit. We'll talk about advising them to quit and to assess their willingness to do so. An effective tobacco screening really provides a roadmap so that we as practitioners can come up with an individual approach to quitting. Learning about what's worked for the patient in the past, what hasn't worked, how dependent they are. We need to individualize our treatment.
And when we talk about effective tobacco screening, we're talking about a comprehensive approach. This is not your mother's yes or no answer. And sadly, what we see is that oftentimes in electronic health records, where there is a prompt for the medical assistant to approach this topic, it's a yes or no. And that is not effective. And what we need to do is try to help even our clinical staff, the medical assistants, the nursing folks, all the people who are out there with the patients to understand what it is we're trying to accomplish. We want concrete, individual history information that we can then use to assess and evaluate a comprehensive approach. So that's why we're spending time today talking about these topics and really getting in the nitty-gritty, because that information is really the bottom line of how you approach their plan for a quit. So where are they on the tobacco use spectrum? We need to ask those questions. We need to ask them about, are they using tobacco products? What kinds of products do they use? They may be using something they don't even know has tobacco in it. And that's why it's so important that we recognize some of the jargon too, because they may be giving us answers of, no, I don't use that, or gee, I used to do that, but I don't do that now. And they're using something else now. There are so many products, and we're going to talk about that next week. I hope you can join us next week. We're going to really get into some of these alternative tobacco products, because even synthetic nicotine is now available, and the liquids that people are vaping are quite interesting. So, you know, this is really a key aspect, is trying to ask them specifically to tell you, to help you know what it is that they use. Now, it's up to you to understand things like the tobacco pack history issue. So if they're using an e-cigarette, it will be a different amount of nicotine than if they're using a regular cigarette, or depending on the device, there may be differences. So it's a very, it can be a little bit tricky when you ask about products. What is their history of use? The smoking history, the pack history. If you don't know how to do a pack history, look it up on the internet. It's very easy to do. It's a pack year history. So you take the total amount of information from all of the years of their use and try to calculate just how much they have been exposed. When have they attempted a quit? This is critically important. When have they attempted? What happened? What products did they use? Did they use products that were recommended to them by a clinician, or did they do it on their own? What we know is that when people do try to quit on their own, they are even less successful than if a clinician is involved. A clinician really makes a big difference. People who try to quit on their own without using any products, about 5% of them succeed. If they go to the store, to a pharmacy, to a grocery, and buy their own products, their own nicotine replacement, their own gum, their own patches, etc., and do not seek counseling from a healthcare clinician, they actually do much worse. They do about 3% success. So going and getting counseling can make all the difference in the world, especially if the counselor or the clinician is a person who knows and is knowledgeable of how to apply evidence-based tobacco treatment. When we talk about the attempted quit, we need to think about what might have happened. Like, for example, let's say they went and they bought some gum, maybe because President Obama chewed nicotine gum. So a lot of people said, oh, I'll go get nicotine gum. So they'd get nicotine gum and they chew it. And you know what? It did not work. And why didn't it work? Because they got nauseated. They got really sick chewing their nicotine gum. Why did they get sick chewing their nicotine gum? Well, it may be because they swallowed the juices. That is not a good thing. Nicotine gum is to be put into a buccal area. They park it, they chew it until it's a little peppery tasting. And when the peppery taste ceases, then they park it and let it sit. And then when they need it again, they do the same thing. So they don't swallow the juices. They let it get absorbed into the cheek area. Multiple quit attempts are the norm. So when we hear that somebody has had 10 or 11, or maybe they'll say, you know what, I have tried so many times that there's just no way I'm going to do it again. You have to know what occurred, because the failures or the lack of success may be the best thing that you can collect in data to find out what didn't work right and what can you do to help them have a successful quit attempt this time. So it's all very important for a long-term quit.
So it's important that we also understand about nicotine dependence. As we said before, nicotine is a highly addictive substance, as probably more addictive even than heroin. So we want to get a feel for how dependent is the patient, and a few simple questions really can give you a good sense of nicotine dependence. How soon after waking up do you smoke your first cigarette? Within 5 minutes, within a half an hour, within an hour, or longer than an hour? So for most people who are highly dependent, they're having that first hit of nicotine, that first cigarette, within the first 5 minutes, and certainly within the first 30 minutes of getting up. Somebody who can get up and take their shower and clean up and go make breakfast and then has their first cigarette after they've been up for more than an hour is much less nicotine dependent. Which cigarette do you hate to give up the most? Again, a sign of dependence is when it's the first one in the morning, because that's the one that's breaking that withdrawal cycle. That's the one that's helping them overcome withdrawal. And then, of course, how many cigarettes or vapes or whatever they're using do you smoke or vape per day? Again, a pack of cigarettes in the United States, 20 cigarettes per pack. So you want to know, when they say, oh, it's a half a pack or it's a pack is 20 cigarettes.
So here's the full list again of the 5 A's. And the reason we put that here is just to show that we're just going to hit on some of the topics. 2 weeks from now, after we talk about e-cigarettes and alternatives next week, the next week after that, we're going to hit you with the number 4 and number 5, the assist and arrange. But today we're doing ask, advise, and assess.
For advising, this is really, as I showed in that first slide, this is where the clinician needs to make sure the patient understands the significant impact of tobacco on their health, on the health of their loved ones, on their future activities, on their lifespan. This is where you want to make sure the patient understands the impact of tobacco use. And as much as you can, you want to personalize this. You want to put it in patient terms. Do they have an underlying illness such as emphysema or COPD that is being impacted by their smoking? Do they have heart disease? Do they have hypertension, diabetes, all of which can be made worse with smoking? Is their focus on their children or maybe their grandchildren? And again, here you want to focus on the negative impacts of secondhand smoke on the well-being of young people. So it's important to understand your patient and what your patient's issues might be and really focus there.
You know, we talk about oftentimes what are the benefits of quitting, because we turn it around for our patients in order to help them visualize how quickly they can benefit. And what is so important is that the benefits begin the minute the person begins to quit. And if they can just understand that and try to ride out some of the early withdrawal of nicotine kinds of symptoms, it is so important for them to be able to say, you know, if I can just do this for 2 weeks, I'm going to have better lung function. Or within 9 months, I'm going to not cough as much or have shortness of breath. Or within 20 minutes, you know, my heart rate and my blood pressure may improve. I mean, those are very significant features. The American Lung Association has a 1-page sheet, and you know, I have it always with me. It's a very easy sheet that you can pull up, and it gives you, you know, what are the benefits when I am going to quit in 20 minutes or in 12 hours or in 2 weeks. So very helpful.
We want to assess the patient's willingness to make a quit attempt. And here again, the focus is on reflective listening and oftentimes using motivational interviewing. We want to find out where is the patient in their willingness to quit. As we said before, 2/3, 70% of patients want to quit. We want to help them by being a team with them to help them quit. So we oftentimes need to address why they're not quite ready to quit today. What is it? Where's the discrepancy between their desire to quit and their willingness to take action right now?
And it's important that you assess them and then make a judgment of how you can approach them. So we use a scale of 1 to 10. It's a motivation scale. I'm sure you've used it for a variety of different procedures in your practices. But what we try to do is aim for a 7. If someone can feel that they are ready to take on another quit attempt and they are at a 6 or a 7, that's a really great place for us to begin to show them how we can partner with them and help them. So you've already advised them that you don't believe, that you personally do not believe that it's in their best interest to continue. And you've told them why. And now you are going to ask them questions like, what are your thoughts on preparing for a quit? You know, what do you dislike about smoking? You know, how would you handle it if we took on a plan for going ahead with this quit? You know, it's time to decide whether you're ready or not, and measure that and see where they are. And then, of course, with motivational interviewing, you'll want to move them up the scale if they are not yet at a 6 or a 7. If they're at a 4 or a 5, you know, you need to act accordingly. And much is written about how to approach the patient who is at a 3 or a 4 or a 5. But it's so wonderful when you can find a way that you have moved them in partnership towards that 6 or 7.
And that's where, again, individualizing the therapy, individualizing the patient's motivations, whether it's their health, loved one's health, whatever it might be, the more information you have from your ask helps you in your assess.
So here's a case example. When a patient is too scared to contemplate quitting, they say things like, I'm just too addicted. I'll never quit. Why should I even try? So can we open this up and talk a little bit about, have you heard a patient say that before? What has happened in your practice, or have you approached this in any kind of a standardized way? We are not seeing. Does anyone want to respond?
Apparently not.
Well, so I'll push on that a little bit. We've got a good group of people here who've got a good number of years of practice. I'm sure somebody has encountered something similar or has an idea on how they would if a patient said this to them. So please don't be shy, folks.
I mean, we can go ahead.
All right,
We'll
we'll give you some more chances.
We'll show you a possible answer. So they said, I'm too addicted. I can never quit. Why should I even try? So the clinician comes back and says, it sounds like you feel it will be a challenge. And it may be. And nicotine dependence can be a challenge, but it's going to be worth doing for a lot of reasons. The reasons we've already talked about, for your health and for your family's health or your friends' health. You're going to have more money in your pocket, etc. So trying to just be very commonsensical with them is really a great way to do it. Here's another case example.
So when a patient's had some bad quit attempts, their answer is, I've tried and tried to go without cigarettes. It's just not possible.
So what would you say?
But while you're thinking about what you're saying, let me tell you what Mark Twain said. Giving up smoking is the easiest thing in the world. I know because I've done it thousands of times.
And that brings up such an important question, a way to approach this. Quitting is the norm. Most people, on average, it takes 7 or 8 quits. Some people will quit 30 times. Sadly, a lot of those quits could have been prevented if a clinician had been educated and helped the patient with an individualized, evidence-based approach. That is the key. And helping people know that relapsing or quitting is the norm is a really great way to take a burden off of their shoulders.
6 to 12 attempts for most people before they have a successful attempt.
It's so important to be able to say, but this time, I feel like we've got a lot of good information. I think we can do this together. Patients need support. And if that means that you may have to have them in for another appointment to especially focus on their tobacco issues, or if that means that one of your clinical team comes out and assists them after they are done, after your patient is done seeing you about another complaint, then that's great. That way you're dealing with a team, and the team actually is far more effective. You can get all of your staff involved. It's really very, very helpful. Even hanging up things like posters around the clinical area can make a difference. And you can print those out off the internet from the CDC. That gives people a feeling that other people have been there. They've done that. They've had similar issues and they've been successful.
And part of this is we shouldn't think of a failed quit attempt as a failure. Rather, it's a learning opportunity so that our next attempt can be more successful. It gives us a roadmap for success.
So here's the possible answer after they say they've tried and tried. It's good that you've had another quit attempt. This time, you'll have a quit plan in place before you quit. We'll make sure of that because we're working together on this. And you will have built a support system with your friends and your girlfriend. And that's part, again, of how we approach this in a commonsensical way. In order to build a plan with the patient, we need to understand who the patient is. You know, is there a spouse at home who perhaps is a smoker also and does not want any part of having their spouse quit? That's very significant, and we need to approach it directly if that's the case. Or is it a spouse who has thrown them out of the house because they smoke and doesn't want smoke in the house and is very willing to help? You know, those are really key ingredients, again, of that history that you take.
And they need to know that there is a partnership between their provider and them, that they're not doing this alone. So when a patient is asked to consider developing a quit plan because they have medical issues like hypertension, COPD, and their answer back to you is, yeah, but I really like smoking. And your answer is, of course you like smoking. What is it about smoking that you like? What would you miss the most if you quit smoking? And oftentimes they would miss the camaraderie of standing out in the cold by the wastebasket outside of their workplace with their fellow smokers. Or they miss sitting around with their buddies watching a football game,
Absolutely.
everybody smoking and enjoying their beverage. Find out what it is that makes the smoking so desirable.
And it'll be different for every single person, and we have to identify that, because you cannot apply the general concepts and have it be effective.
And oftentimes the next question is, what would your life be like if you didn't smoke? You know, what are the things you'd be able to do? Maybe your kid would let you play with your grandchild.
So when a patient is scared about the overwhelming thought of trying to give up cigarettes, you know, I'm 65. Does it really matter anymore? Isn't the damage already done? You can say, I suppose you're wondering if you can benefit right away. And the answer is yes. Even within hours, you can see changes. Within 12 hours, the carbon monoxide in your body decreases and the amount of oxygen in your blood increases. And if we know that as clinicians, and we can say that, you know, if we have our little cheat sheet here and we use it, it can be very powerful because people are looking for hope. People want to quit. It's fascinating that most people who begin smoking cigarettes want to quit very soon after they begin. Sadly, this is a disease of very young people. And usually people who begin to smoke are in their teens. If they don't begin to smoke by the time they're 21 or 22, they won't smoke. So what happens is, even though they want to quit, it may take 10 years before they finally say, I've got to quit. So most people who begin to want to quit and verbalize it are oftentimes in their late 20s. So we need to capture those people. Certainly we need to prevent. Okay, that's the bottom line, is helping people prevent. But if you can capture the people when they are just like hanging by a thread and they're sick of it, they don't like smelling like smoke, they don't like buying it and spending all of their money. You know, there are two ways to prevent increased tobacco purchase. One is through tobacco taxes, and the other is raising the actual price of the cigarettes. If you look at Chicago and New York, they have much lower rates of use. Why is that? Because in Chicago, buying a pack of cigarettes is as expensive. It's more expensive than anywhere else, $12 to $13. And people are not willing to drive to northern Indiana, which is an hour-and-a-half ride, to spend time getting cigarettes and then bring them back. So it's very important that we try to implement those concepts and understand them. It's, Glenn and I often talk about how, as we have learned about tobacco and evidence-based tobacco treatment, it's one of the most commonsensical, and I don't want to demean it, but I'm going to say the word simple things. If we can help educate clinicians to understand it and use commonsensical jargon, talk with your patients, because that will really empower your patient. And finding ways, to help them clean out their car, or to help them grab a carrot instead of holding a cigarette, or getting the cinnamon toothpicks that are so helpful for people to put something in their mouth and suck. Those are incredibly important things, but they have to do the work themselves. They have to understand why they started smoking, and we have to help them identify that. We can't do it for them.
And just getting back one more time about, I'm 65, does it really matter anymore? No matter what age someone quits smoking, you add to their life expectancy. Even someone who is 65, you can give them several additional years of life if they will quit smoking.
So the bottom line is to individualize treatment, to always document. If you are using billing codes, and there are many billing codes now that allow us to get paid for these services in a very comprehensive way, make sure you document. Listen to your patient.
This is a matter of individualizing the history taking so that you can personalize the therapy. So I'm going to show you the glamour of smoking on a short video. We all see the people who smoke because it's glamorous. And so we just want to show you a little of the glamour of smoking. These are some of the resources that are readily available to everybody, and strongly encourage you to look at these resources. We're very proud of the podcast that we did for the cardio statewide project here in Ohio. If you have half an hour or 20 minutes to listen to the podcast, I think it'll give you a great overview about tobacco cessation and how to treat people with tobacco issues. I think that's going to bring our formal.
Yeah, let's talk about what you all are seeing